I'm here with Terry Kim. Terry, I'm a big fan of glues. I mean, in ophthalmology, although I've got little kids, I'm a big fan of glues in a lot of contexts. And they've changed the way that I approach conj autografts. I really rarely suture now.
Right.
You presented on adhesive use in anterior segment surgery. Can I get you to talk about it a little?
Yeah. Actually, we've been running an instruction course here at AAO and at ASCRS for the last, I want to say, 7 or 8 years. And I think people are beginning to realize alternate ways to close wounds because, as you know, Josh, a lot of surgeons are moving away from using sutures for a number of reasons. It takes time to put that in. There's a skill acquired for doing so. Sutures themselves also cause complications. If they're tight, they can cause astigmatism. You have to remove them generally, at least in anterior segment surgery, if you're putting nylon in, which requires patient coming back to see you. In addition to that, you can have problems with neovascularization, abscess formation, inflammation with sutures. So we've been looking at different adhesives that are currently off-label use, which include both cyanoacrylate and fibrin-based adhesives for various anterior segment procedures. So that includes, as you mentioned, pterygium surgery is a very popular one with the use of fibrin-based adhesives off-label to secure the conjunctival or amniotic membrane graft onto the scleral surface.
Sure.
And it's worked out great. No sutures at all. If you look at the peer-reviewed literature, it shows that the recurrence rates and the success rates are very comparable to that with suture. So I think that's been a nice advantage because, as you know, it takes a lot of time with a pterygium excision and conj autograft to put all those sutures in.
And the patients are much more comfortable with
That's
the glue.
That's the key factor is the patient comfort. So you'll get less phone calls after you do that. What's interesting to me is how that's really spread to other anterior segment procedures.
Talk about that.
So we have, I think, about 7 faculty in our course, instruction course on adhesives. So, for instance, Chris Rapuano from Wills talks about the use of cyanoacrylate for corneal perforations. And we've all used off-label use of cyanoacrylate adhesives for these little perforations in the cornea, right? Because we don't have anything otherwise to temporize closing of the wound until you can do a patch graft.
And it works well.
It works very well. But cyanoacrylate, when it polymerizes, as you know, it's very hard, brittle. You have to put a bandage contact lens, and then, your kids, anyone who plays with it, you'll know it gets stuck to your fingers very quickly, right? So probably not the ideal material for the surface of the eye. Robert Noaker talks about the use of fibrin adhesives for his glaucoma shunt procedures, securing the, scleral patch graft and closing the conjunctiva. We have David Ritterband, who talks about the use, and he's done some very interesting study looking at a modification of the cyanoacrylate material, which actually you can buy in the pharmacy. It's Johnson & Johnson's product. I'm blanking on the actual name, but it's actually a Band-Aid it's cyanoacrylate.
Oh, yeah, I know what you mean, yes.
You're talking about, right? Instead of putting
Dermabond.
Dermabond is now the adhesive that you can get in the emergency room, but you can actually buy this stuff in the pharmacy or grocery store, which is right next to your Band-Aid, same company that you just put on, but similar concept. That's right. Then I have David Harton, who talks about the use of fibrin-based adhesives for addressing flap complications after LASIK, because you can develop epithelial ingrowth, and when you treat that, it can recur. So he and I are in the midst of publishing the use of fibrin-based adhesives along the edge of the flap.
But that's interesting as a barrier.
Yeah, as a barrier, exactly, to prevent epithelium from growing in. Then we also have Amar Agarwal, who has very popularized now the technique of securing a secondary lens into the sclera with use of adhesive, fibrin-based adhesive, instead of suture.
By externalizing the haptics.
The haptic into a scleral pocket, and then putting the adhesive on top of that. And then Jonathan Rubenstein recently joined our course, who talks about the use of fibrin-based adhesives for the use of ocular surface procedures like limbal stem cell transplants.
Oh, really?
Yeah. So it's really begun to spread. Now, the big thing everyone wants to know about, what about cataract surgery?
Right.
Right? We know that there is a chance that these corneal wounds after cataract surgery may not be as sealed as we think they are. and people have published on this, and I've made some case reports of some interesting findings of perhaps an eyelash that gets embedded into the wound the next day. But a company called Ocular Therapeutics just recently completed a very interesting trial where they actually compared the use of their Reshore sealant, which is a unique polymer that actually degrades on the eye, and it's completely synthetic and it's transparent, very comfortable. You won't need a bandage contact lens, compared to suture, which we know is the gold standard for closing sutures, for closing wounds. And the other issue with that is stromal hydration. I think we all stromal hydrate after cataract wounds, but studies have shown that stromal hydration doesn't last. So this study actually looked at it in a prospective fashion and actually found that the use of the Reshore sealant was superior, not only non-inferior, but superior to sutures in terms of closing these wounds, and in terms of 8 times a higher rate. So this is a very surprising finding. The other interesting finding in the study is they found that 50% of the eyes prior to randomization to either group leaked without any provocation. And remember, this is a clinical study. We had to systematically look at this. The point being that I think a lot of surgeons don't look at their wounds at the end of cataract surgery and may be surprised that they actually leak, because it did require the use of fluorescein staining on every wound to make sure they leaked in order to qualify to enter into the study. So those two facts show us, number one, that these wounds leak probably with a higher rate than we think, and number two, now we have an alternate means of sealing these wounds that I think will be a very nice alternative to suture because of the disadvantage that we mentioned earlier.
Terry, it's great stuff. But as a teacher, the only thing that I can think of, I know I'm sure you know what I'm going to say next, is that as we've moved to clear cornea, there are precious few times that the resident suture in the first place, and now with glues, boy, I'm starting to feel more and more like a dinosaur.
Well, it's an important point, because I think we all teach our residents. And residents now, fellows now, are not suturing as much as just as you said, right?
But it's a skill that they need.
It's a skill that they need, and they also need to look at the wound to make sure it is sealed, because again, stromal hydration probably doesn't last. So now you have something that you can actually put right onto the eye. If you look at the timing of it, much quicker than suture, and then if you have something like this, I think it just peace of mind in terms of protection over that wound, because we all know the last thing you want is an infection or complication related to the wound.
Great stuff. Terry, thank you very much for sharing time with us today.
Thanks for having me, Josh.